webinar video, Alba?
Okay, good evening.
No, wait.
Wait.
We are waiting for the video. You're like too eager to get started, Salvatore.
Okay, I think it's in the progress, okay.
Bonjour à toutes et à tous. C'est bientôt la Vein Week, la semaine de la veine.
It's very important. Both public and health professionals are aware of appropriate venous lymphatic management.
Incluso más del 50% de la población podría estar sufriendo enfermedades venosas y linfáticas.
Não se esqueça, tromboembolismo venoso é uma das principais causas de morte e que pode ser prevenida.
И че по-настоящем лимфедема се определя като скрита епидемия.
السلام عليكم جميعا. هل تعلمون أن الدوالي ليست فقط بالسقيم وإنما أحيانا توجد في أوردة الحوض وقد تصيب النساء في منتصف العمر، وأهم شكوى في هذه الظروف هي وجود آلام مبرحة في منطقة الحوض قد تتعدى 6 أشهر، فحين ذاك لابد أن نفكر في أوردة الحوض قد توجد بها دوالي. وشكرا.
იწვევს ეგრეთ წოდებულ მენჯის ვენურ დარღვევებს, რომელიც წარმოადგენს გენდერული თანასწორობის საკითხს, განსაზღვრავს როგორც დავიწყებული დაავადება.
Ανυπομονούμε για μια εξαιρετική εβδομάδα φλεβών που προάγει μια υπέροχη υγεία των φλεβών και των λεμφικών αγγείων.
أنتم مدعوون في الفترة من 4 إلى 10 إبريل لإنشاء مبادرات أسبوع الوريد في بلدكم.
Promuovendo educazione basata sull'evidenza.
社会の方々や施設の方々にお知らせしましょう。
नमस्ते, हमें अपने एरिया में वेन्स और लिम्फेटिक्स की हेल्थ को इम्प्रूव करने के लिए एजुकेशन एंड कोशिश करते रहनी चाहिए। Thank you.
Interactuando con todos nuestros colegas alrededor del mundo.
各位同道们，早安、午安、晚安。
And good vein lymphatic health. See you at
Vein Week.
Welcome everybody, and indeed it's Monday, so let's wish all of you a nice week, but first of all a nice Vein Week. We are on behalf of the WIN Foundation, of course, but also of the European Pelvic Venous Alliance, a stellar group recently created by Professor Zaza Razarashvili from Georgia, and indeed this is an initiative that is part of Vein Week Georgia. We go back virtual after an amazing, unforgettable in-person experience at the World Fair, the Universal Expo. So I'd like to take this chance to deeply thank all the ones who took part in this global teamwork. And it's my honor and pleasure now to give the word to Professor Zaza Razarashvili, who will introduce the vision and mission of today's activity dedicated to pelvic venous disorder, that is extremely honored to see the European Board of College and of Obstetrics and Gynecology co-working with the vascular experts on the topic indeed of what has been defined as the forgotten disease in a publication, that is indeed the pelvic venous disorder. Zaza, over to you in Georgia.
Yes, thank you very much. First, thank you, the WIN Foundation organized this very needed webinar. It's practically is a continuation of our first online meeting of European Pelvic Vein Alliance, and I'm happy to see with us our colleagues from European Board and College of Obstetrics and Gynecologists. And I think these two online meetings, previous and today's, will be some basis for future direction, for future decisions. And I hope that we all also talk about the hottest topics in case of pelvic venous disorders. Thank you.
Thank you so much, Professor Lazzarashvili, and it's truly an honor to welcome two giants of the OBGYN field, Professor Tarlatzis and Professor Grimbitz, for their welcoming words.
Thank you, Sergio. Thank you, dear colleagues. I'm Basil Tarlatzis, President of the European Board and College of Obstetrics and Gynecology. And when Professor Giannesini contacted me about this project, although it is not my field of expertise, I immediately realized that it is something that has been overlooked over the years, and it would be extremely important to try to bring the disciplines together in order to address these issues in a more comprehensive way. And that's why I approached my surgical colleagues, Professor Grimbidis, Professor Ferreira, Professor Saridogan, who are more actively working in that field, in order to be able to represent also EPCOG in this initiative, because I believe strongly that it is an important initiative. And therefore, and also they are very active members of the European Society of Gynecological Endoscopy. So I think we can have a very good blend and a very good team to address this issue. And therefore, I will be very, very happy to follow the developments from your initiatives concerning the pelvic vein and disorders. So I would like to wish you great success. I'm sure about that, and I will be next to you to help you as much as I can. But I trust my colleagues will represent us at the very high level. Thank you very much, and nice to see you all. Thank you.
It's us deeply thanking you, Basil, because you really remind us of Professor Caprini, who is our hero in our community. Is the one of the Caprini score. I hope you use it, or you're familiar with that also in the OBGYN. And he really taught us that the bigger you are, the simpler you are to be approached. And despite your huge professional figure, you have been really immediately reactive to that. And I really thank you for this. That has been really appreciated. As it has been extremely appreciated having with us another giant of your field, Professor Grimbitz from Greece. So if you like to have a welcoming word as well. You are on mute.
Yes, thank you very much. I would like to thank you personally, and also Basil, I mean, for your kind invitation to participate in this very important initiative. I think that really the pelvic vein syndrome is a forgotten, let's say, issue in our field. Actually, in the past, there were a lot of discussions about that, but it was, in the differential diagnostic of pelvic pain. Now, we have probably to think about it again, but there were some problems in the past concerning the diagnosis and also, the real contribution of this in the pelvic pain. So actually, we have to rethink about that, and this is a very good opportunity, having a team of vascular experts, to discuss again and to see again the place, of pelvic pain syndrome within our field, within the pelvic pain, in the woman. So this is why actually, I approached two very experienced colleagues, Helder Ferreira and also Erdan Saredogan, very active, in the European Society of Gynecological Endoscopy. And we would like just from the EBCOG part to participate to discuss. There is still place of discussion and also to clarify a lot of issues. Thank you once again, for your invitation, and I hope that at the end we will succeed, to bring something, to the scientific community, which will be really clinically useful. Thank you very much.
Thank you so much all, and we are perfectly on time now to move forward with the scientific part. This is an atypical webinar that is basically based on a 20-minute insights from the vascular community. We asked everybody around the world to send eventual comments on hot topics from a vascular standpoint in pelvic venous disorder. Then there will be another 20 minutes dedicated to the same activity, but on the OBGYN side, and then we will have 30 minutes of multidisciplinary discussion. So it is your honor to introduce the first speaker who sent a contribution. These are like very quick contributions, 3 minutes just to put on the table things we consider worthy to be discussed. Zaza, would you like to introduce the speaker? You're on mute. You're on mute, Zaza. We cannot hear you. Can you hear us, Zaza? If not, to proceed, we will just go with the video. Here you are.
So, I want to introduce Professor Luay Altarazi, who is a great specialist in this field from Lebanon.
Here we are with this video.
Hello, I am Dr. Altarazi, and I am going to talk about unreported and unknown aspect of pelvic venous disorders. In females, we all know the classic manifestation, but we have found a lot of other like pulmonary embolism, hemorrhoids, hematuria, hydronephrosis, sciatic pain. And since we are working in male pelvic congestion syndrome this last 4 years, we have found another aspect like tenesmus, prostatic hypertrophy, hematuria, urinary lithiasis, hemorrhoid, infertility, male impotence, etc. Male pelvic congestion syndrome is very common, and as you can see here, the spermatic vein can give a lot of varicose vein in the pelvis, and even the special spermatic vein in the scrotum communicates with the prostatic and with hemorrhoidal plexus here. And gut and associated has shown in many articles that the blood rich in testosterone from the testicle is derived directly in case of reflux to the prostate, causing prostatic hypertrophy and causing impotence. And here we can see the communication with the lower limb varicose vein. Sure, we can see many other unreported aspects here. This one is the gonadal vein, but this one is the urethral vein, and the urethral vein can cause an important pelvic venous disorder and dilatation and can compress the ureter, and as you can see, you must have microcatheter to go in it. And other point of compression is the right ovarian syndrome and the left urethral compression syndrome. They are not so rare. Hemorrhoids is sure a part of pelvic venous disorder, and we must look for them. Here is the communication. And we worked a lot on sciatic vein in pelvic venous disorder, and you can see this huge sciatic vein, and we can follow it in the rear side under ultrasound guidance, and we can approach it directly. We approached it more than 60 times. And so sometimes under fluoroscopy, here you can see the marginal sciatic axial vein, and you can follow it till the pelvis, and you can treat it from below. And we have published our first cases 2 years ago, and now we have more than 600 cases of sciatic vein, and we have shown the anatomic distribution differences. And we have found what we called the hip congestion syndrome. These guys have hip pain, and also the piriformis congestion when you see the superior gluteal vein are compressing the sciatic roots. So thank you very much.
Very, very nice presentation from Dr. Altarazi. And now next speaker,
Since this is a really round table, I think if somebody wants to jump into discussion already, because we have like 3-4 contributions to listen to. So I don't know if somebody wants to jump in on the topic. We started with this one of male that looks like paradoxical in a pelvic venous disorder, usually for females, because indeed it's a matter of gender equality. So for sure, I think one very basic thing to be discussed is how to reach out to the population and also to the colleagues, because before starting this webinar, we were indeed talking with Professor Tobias Hirsche from Germany, mentioning like how in Italy and in Germany, there was like this lack of communication between the OBGYN and the vascular ward. I see Pierluigi has a raised hand, and I just take this chance to remind all the audience they are following us also on Facebook. They can make comments in the chat and also question and answer here in Zoom. Luigi.
Yes, welcome everybody. It's a pleasure to stay here. Now, just a consideration. Last year, we organized with the pharmacist a little questionnaire of chronic pelvic pain. And the results was that 40% of women have chronic pelvic pain. Half of these women have, of course, endometriosis or other gynecological disease, but the other part was vascular problems. So effectively, this is a forgotten disease. Probably we can define the Cinderella, the chronic pelvic pain, not only the phlebology, but also the chronic disease, venous disease is a very unknown condition, but is very important for the quality of life of the patients.
Pierluigi, you just mentioned an important part in the quality of life. So I'd like to ask to our OBGYN colleagues, if you have some specific quality of life score that you are using for assessing this condition in your patients. We have giants from the field in OBGYN, so I don't know if you want to take this comment. Professor Greenbitz or Professor Ferreira. See also Professor Sarito again.
Actually, I'm really impressed, from the percentage of the women that they have, problems, of pelvic pain, 40%, and, your, let's say, comment that half of them, they might have, let's say, pelvic pain syndrome, but this is something, have you published that, as a research or something like that? No. Because actually, I will make a comment, the definitions probably later, what is, so I think that, the main problem is, how we define this, and this is a problem, how we diagnose this is another problem, just to be reliable, this is another thing, and what is the real contribution of this, and actually, what are the treatment options afterwards. So this is the main comment, because actually I'm impressed, from the fact that 40% of the women reported, some, let's say, pelvic pain symptoms, which is quite high, and not only half of them, they have endometriosis or other diseases. Actually, it's not endometriosis. Actually, it's also, adenomyosis and other causes of pelvic pain. So there is still, I think a lot of things that they are open. And I don't know if, the other colleagues, Helder and also, Erdan, would like us to make some comments on that.
Hello, everyone. It's a great pleasure to join this group. I think it's really important to share the knowledge and experience between our specialties. mainly if we are speaking about pelvic pain in women. And in fact, we as gynecologists, we face it in our daily clinical practice. So joining efforts towards a better diagnosis of some situations that sometimes are not so clear. For example, I'm very dedicated to endometriosis and adenomyosis, and the numbers are impressive. When my colleague Professor Grigoris said 40%, it's even more impressive. So surely there are other causes of pelvic pain, and then together trying to also develop some scientific work, we should define the criteria, for example, for pelvic congestion syndrome, for vulvar varicosities or other pelvic venous disorders that can explain the pain. So from my side, I think that together we can work towards a better care for women worldwide, and you can count on my collaboration. Thank you for this opportunity and for the initiative.
Thank you so much, Professor Ferreira. I will go back to you later on with a question, if you have time, about endometriosis and dilated veins, because of course one of the reasons why we are doing these, I'm getting to you, Tobias, don't worry, I'm getting there. But what I was just wanted to prepare for the next question, Professor Ferreira, in case of dilated veins at the same time endometriosis, how do you usually behave in OBGYN? What do you stage, and you do first one and then eventually the second, or what is your advice in a situation like this? But let's go to Tobias, to Germany, and then, of course, if we have time, we go back. And it's my pleasure to give the mic to Professor Hirsch from Germany, German Society of Phlebology.
It's not a comment, a more call for help. These 40% of women suffering from chronic pelvic pain is a frequently cited number. But my problem is, where do I find these numbers? Where do I find this data? Other data is every second woman in a gynecological practice. Can anybody of you send me the literature? I know that there must be the literature, but I don't have it. I would like to use it for review issues, but I don't have it. Maybe one of you can send me his email address in the chat function, so I will keep in contact to you.
I think the problem is always the blurred line in between vascular and OBGYN conditions over here, and that indeed is leading me back to Professor Ferreira. In case you have a patient with a suspected pelvic venous disorder, so say that you find dilated varicosities, but at the same time endometriosis, how do you usually approach these patients? Or Professor Sarid again?
But following on what Professor Greenbitzis and Ferreira said, I just want to add a few things. So they obviously you have described pelvic venous congestion syndrome as a forgotten disease. So in the UK, obviously, I can agree that maybe it's not given as much importance either, but it's not necessarily forgotten disease. There's a lot of skepticism about the diagnosis, and that's probably the main issue. It's not necessarily lack of awareness, but presence of skepticism. And presence of skepticism is based on lack of data, convincing data about objective parameters of diagnosis, and also lack of data on efficacy of treatment from randomized controlled trials. And I think kind of, when we are talking about unmet needs, what are the unmet needs? Probably these are our main unmet needs. So you need to convince people, well, at least I can speak for UK, that we need to convince people that this condition exists. And secondly, there are treatments that work better than doing nothing. So I think kind of these are the main points that I would like to make at this stage.
Thank you so much, Professor Salido again. Professor Ferreira, would you have a comment on the overlapping scenario of endometriosis and pelvic venous disorder? Because one of our concerns, of course, is over-treatment in the pelvic venous disorder scenario.
Yes. The criteria for endometriosis and even for adenomyosis are at the moment clear, and it's very important to listen the woman, to listen the symptoms. Most of the times the pain is cyclic. It follows the menstruation, or it is related with the ovulation. So it can differentiate the pain from other causes. Also, it is well established that the gynecological exam gives us important new information concerning the degree or the severity or the stage of the disease. It's something very relevant in the diagnosis, and more we have the ultrasound, the MRI, and finally the laparoscopy that gives us the diagnosis, the presumptive diagnosis, and also the histologic diagnosis. The pelvic vein disorders that basically are divided in two groups, the vulvar varicosities and the pelvic congestion syndrome. There are also some criteria, but basically what I say at this moment is that is relevant to differentiate is the symptoms or the complaints of the woman are more associated to endometriosis or not. So if they are more associated to endometriosis, probably if we treat the endometriosis, we can improve the patient quality of life. If the pain is not suspicious of endometriosis, of course, we have to focus on other reasons. And I believe that there are some situations that the pain is caused by both causes, venous disorders or inflammatory pelvic situations like endometriosis or adenomyosis, and then we have to treat both at the same time. But the diagnostic criteria, listen the patient careful, because endometriosis is a heterogeneous disease, because it can appear in different locations and it can have different symptoms. But if we listen carefully the patient, I think we can suspect the diagnosis, and then we can target our approach, our treatment in the best way.
Thank you so much for your answer. Of course, my question was to put on the table an unmet needs that, up to my knowledge, there is no study where you have the same patients assessed by an OBGYN expert and by a vascular expert, because we have to carefully listen to the patients, as you said, but it really depends on who is listening. If it is an OBGYN listening, or if it is a vascular listening, because I think we are more prone to think immediately pelvic venous disorder on our side and eventually endometriosis on the other side. And in terms of quality of life and scores, maybe there is some overlapping in the symptoms that might be confunding. So I think a nice thing would be looking at the literature if there is such a thing like an evaluation of the same patients by two different perspectives, and see how many times we agree or we don't agree. Or maybe there is already there in the literature, and it would be good to know. Professor Grimbitz, I see your hand.
Yeah, so I think that, if we would like just to be successful, and in evaluating the patient, what is the reason of the pain, we need really objective criteria in diagnosing, the disease. So for endometriosis, as Helder, already presented, and for adenomyosis, actually we have some objective criteria based either on imaging techniques or in laparoscopy. So as Professor Saridogan Erdan, told before, the problem with the pelvic vein syndrome is that we don't have objective, let's say, criteria for diagnosis. So if there is no objective criteria for diagnosis, you cannot put this, in a reliable, way in the differential diagnosis of pelvic pain. And this is why all these years, this is the one point, this is why all these years, there were a lot of discussions, maybe in UK, as Erdan presented before, is on the table, but in Greece or maybe in other European countries, I don't think that it's on the table. Even in SGE, when we are discussing about pelvic pain, the pelvic vein syndrome is not on the table. So because there are no, definitions, there are not objective criteria of diagnosis, and this is why, this syndrome is not on the table of in the differential diagnosis. So this is the main problem for me. So we have, if we decide to make a group, I think that the first thing is just to define what is pelvic vein syndrome and what is not. And also, by using non-invasive techniques that we have in our hands, not only angiography, but also, ultrasound and Doppler, or maybe other techniques, MRI, we have, to see, how we will diagnose the disease. Because in this way, we have some, as already Erdan, presented and commented, if you have, objective criteria, then you can see the contribution of this syndrome, of this disease. We cannot, I don't know if it's a disease, probably it's a syndrome. So in the contribution in pelvic pain. So this is something very important for me. And you can see that even, when you organized, this webinar, actually there is no structured presentation about the syndrome, about the pelvic vein syndrome, because actually there are a lot of open issues, from the definition up to the treatment. So if you have a lot of open issues, you cannot design anything, you cannot speak about that. It's really, something that, it's really in the beginning for me. And this is probably, something nice for us. If we would like just to do something, we have to start from the beginning. We have a lot of tools now, because actually Doppler, is a new technology since, let's say, 20 years, maybe, the experience since 10 years. We have 3D ultrasound, now, we have MRI, probably, angiography, so we have a lot of new tools, and we can reapproach, this topic with new elements. So this is something that we have, probably to put on the table and to see how we go on. Because
Absolutely.
the other causes, for endometriosis, adenomyosis, it's a little bit more clear. There are still, of course, you asked what is, the contribution of pelvic vein syndrome in cases of endometriosis, because we know that in some patients with endometriosis, you treat endometriosis and then you have still pelvic pain. So probably pelvic vein syndrome is on the table, in this part of patients. But if you don't know from the beginning how to reach this, how to define, how to diagnose, then there is a problem.
And thank you so much for your insight. I was just going to give the word to Professor Lazzarashvili because I was sure he was going to get into the topic, because indeed on our side, as vascular, we interpret the presence of the reflex and the related symptomatology as an objectivation of the fact. But I'd like to have Zaza commenting on this.
Yeah, it's very, very interesting discussion, and it's was very interesting for me some differentiation about with the pelvic congestion syndrome and the vulvar varicositis. Yeah, as Dr. Ferreira described it, two big group of pelvic venous disorders. I also introducing this group of conditions is compressive syndromes, which are also the part of pelvic venous disorders. First of all, yes, I agree with you that there is no correct definition what is the pelvic venous disorders. This is the new term which will cover all venous pathologies, chronic venous pathology of the pelvis. I want to describe that the situation with the diagnosis of pelvic venous disorders not so dramatic, and the I want to introduce the document of your International Union of Phlebology. It's consensus document of according to diagnosis and pelvic venous diagnosis and treatment of pelvic congestion syndrome, which was published 3 years ago. And there was a basic document which complete all our knowledge about the pelvic venous pathologies. We can put this document as a basis also with the your document, some guidelines maybe for the diagnosis of endometriosis and other some relative gynecological pathologies, and to find the correct way to correct differential diagnosis of these two or many other gynecological conditions, for the vascular and some gynecological pathologies, differential, some concrete and strong definitions between these two groups of pathologies. It's possible to do, and one of the main goal of the EPVA is to make the diagnostic protocol more strong and correct, I think.
And I think what we could do here is, for example, on our website, if you like, or on whatever website, we could put literature that the colleagues from gynecology think we should really know from their field, and we could put the literature that we consider important for us, so that we can on both sides have a look at that, and eventually the next document will be together rather than just from the two sides. So I think this could be something we can take home from today. So if there are no further comments, just for the sake of time, I would move forward with another contribution that in this case, the first one was coming from Lebanon, this one is coming from Paraguay, and this is Professor Agüero, who is now running a splendid vein week in Paraguay, so we thank her for her contribution.
Pelvic venous disease and mental health issues are related or not many times. We need to perceive and recognize when is a psychological component of the disease and when is depression. The subject remains a taboo for many women, and its multidisciplinary approach a challenge. It requires a unique perspective to evaluate it truly and design our future steps. Thank you.
And we thank her. I think this is another major point. We used to say, I'm used to say that we don't do just sclerotherapy. We do sclero and also therapy to our patients. It's a little joke to say that there is always a strong psychological component, and we know this has been associated with the disease as well. So is there any psychological evaluation that is done from the OBGYN side when you do this evaluation, for example, of endometriosis or similar conditions? Do you have any score you suggest us to use for these female patients? I don't know if some of the OBGYN colleagues, guys, would like to take it from here.
Yes, okay, Sergio. One of the main problem which is a presence on the case of pelvic pain is and have the great social influence of the life of the family is the dyspareunia. Yeah, and I have many cases when the family cannot understand the ladies don't receive the correct diagnosis what they have. Many different doctors told that she is practically health, but as she have the dyspareunia, it was the some reason for in family some disturbance here and inconvenience. And I think this also have the influence on the some mental status of the woman, and it's a main problem. And also in some East countries, there is a problem of diagnosis, primary diagnosis, because many women don't want to talk about their problems. It's also very problem, and it's also have some real influence on their mental status.
Okay, what about NSC Professor Sarido again there, raising hand?
Yes, so in terms of assessment of the patient, including psychological assessment, obviously there are tools that are frequently used in well-organized pelvic pain clinics. This is probably less so in general gynecology setting, but if a patient is attending a multidisciplinary pelvic pain clinic, usually there are standard forms or questionnaires are used. For example, frequently an SS short form 36 is used, and an additional anxiety related form is used to assess psychological morbidity. So I think there are a number of different questionnaires available. Whether these are routinely used depends on how the clinics are organized. But as I mentioned earlier, they are kind of mostly used, commonly used in organized pelvic pain clinics.
But apart SF36, like disease-specific ones are there, like?
Well, disease-specific ones are for endometriosis. Obviously, we have disease-specific one. We commonly use this one, EHP30. Endometriosis Health Questionnaire 30. There is a shorter version of that. These are validated specifically for endometriosis patients, and then we use them. I'm not aware of any pelvic congestion syndrome one, and maybe this is something that may need to be developed.
And indeed, I think we should really create this web page where you put, for example, these tools that you have, so we can understand more. That would be greatly appreciated. If there are no other comments, we move with another contribution that in this case is coming from Italy, and we have the pleasure of having actually the author of the comment. Vittorio, you are here. Would you like to talk, Vittorio, or would you like us to play the video? Vittorio Gallo is a colleague from Italy, dear friend and expert.
I prefer if you go with the video.
Okay, here the video.
Good evening. Thanks so much to Dr. Gianesini for this opportunity. My name is Vittorio Gallo. I am a surgeon from Italy. My topic today is to encourage the use of medical compression stockings during the pregnancy. There are many situations in which venous disorders can appear during a woman's life, but pregnancy represents a particularly important moment. And I'm not just talking about the thromboembolic risk, but also about symptoms affecting the lower limbs, such as pain, swelling, heaviness, paresthesia, itching, symptoms that are related to chronic venous disease and which often appear or worsen during the pregnancy, not least the risk of developing varicose veins. I believe that intercepting these issues and trying to improve them is quite important. Even if there is no clear evidence that graduated compression stockings can prevent the emergence of gestational varicose veins because it is a multifactorial problem. An evidence-based consensus statement published on phlebology in 2018 recommends with grade 1B the use of medical compression stockings to improve venous symptoms, improve the quality of life in the patient with chronic venous disease, and to prevent edema or reduce it if already present. It has also been shown that elastic stockings significantly reduce the incidence of reflux in the great saphenous vein at the saphenous femoral junction during the pregnancy. Different types of yarns and different type of wave used in the manufacture give elastic stockings of the same therapeutic class dynamic characteristics of extensibility and elasticity that are profoundly different from each other and with a different impact on the patient. Therefore, a good knowledge of the materials is essential. I believe that the comparison between specialists from different disciplines on common issues is very important. In this regard, we are organizing for next September in Altino, near Venice, a meeting where we will talk about various aspects and the clinical pictures that transversely involve gynecologists, phlebologists, and proctologists. I hope to meet you soon in Italy, and thank you very much for your attention.
We thank Victoria, and I think here on the table there is, of course, interconnection between pelvic venous disorders and the lower limb varicosities. I would be curious to know how you perceive that the graduated compression stockings in the OBGYN ward in these patients with eventual pelvic vein dilation, because the way we look at this is patients at risk of developing swelling, and as Vittorio was mentioning, we have an indication 1B of using graduated compression stockings whenever at risk of developing swelling. So I don't know if the OBGYN colleagues would like to jump on the topic of the eventual use of graduated compression stockings in patients with dilated varicosities. No one? So look, either you don't use it or you don't believe it, or it's not a major topic, because for us, in reality, it is a major topic, the one of graduated compression. And you see a lot also of the inappropriate prescription of not properly certified stockings in patients who are having eventual symptoms related to edema. I see that you're there with a raised hand.
Yes, Sergio, about the using of compression stockings for the prevention or the treatment of pelvic venous disorders. Yeah, it's a very new topic, and practically there is no real evidence about the effectiveness of the using. But if we look in future, I think because of the huge communication between the venous systems of lower extremities and pelvic, it's maybe compression syndromes, compression stockings, compression materials give some benefit for the prevention of the pelvic venous disorders. But it's we need evidence, not as clear something on this field.
Yeah, and thank you, Zaz. And again, in that page that I was mentioning, we could put the few papers we have. Gavrilov, who is part of the EPVA, was publishing on the use of compression garments just at the pelvic region rather than normal stockings, showcasing some differences. But of course, these are preliminary studies and it would be interesting. I'd be really interested to also survey in the OBGYN world the use of stockings to understand if there is a potential there or not. If the colleagues from the OBGYN don't have any contribution they want to put on the table, we go on with the one of the vascular, if you like. If not, we go back to you guys. Would you prefer us to go on with other topics?
Yeah, my Professor Bokuchava had some about this for this webinar according to stockings or some contribution for the webinar.
For the webinar, because the next one was Elena Goranova, but since Mamuka is a gentleman, I'm sure he will go first with Elena, and then we will have Mamuka for sure. And let me introduce.
Okay,
no, wait, that tell me, is there something?
Yes.
Thank you so
much.
For you?
Yeah.
No, because I see is raised hand. Okay. So we go with Elena, Mamuka, if it's fine for you, and then we go to you. Okay.
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 Hi, dear colleagues. Thank you to Professor Lazarashvili and to Professor Genizini to invite me in this interdisciplinary webinar. It is a great pleasure and honor for me to meet here different colleagues from gynecology, angiology, and vascular surgery. So let me present my case. Do you have the recorded video?
You went so fast I didn't have the time to introduce you properly, because Professor Goranova is a dear friend, but also a greatly esteemed colleague from Bulgaria. And she's actually going to have a nice meeting this June, where I'm sure we'll touch also the topic of pelvic venous disorder. Here is her case, and then we will discuss.
Thank you. Hi, dear colleagues. I would like to share with you a rare case of arteriovenous malformation. It was a 42-year-old woman with presence of chronic pelvis pain, on the left side heaviness and painful menorrhea for the last 3 years. During the exam, there was no varicosity on the left leg, neither on the vulva. The color Doppler sonography showed a turbulent flow velocity waveform. The chaotic or turbulent flow results from the area being filled with numerous vessels occurring in all directions. The diagnosis of arteriovenous malformation may be made from these findings on color Doppler ultrasound, but confirmation of the diagnosis is usually achieved by angiography. The performed contrast angiography, phlebography, found out a highly vascularized mass around the left ovary, dilated ovarian vein due to the hypertension. You can see the selective ovarian venography. Both venous and arterial abdominal pelvic vessels were visualized with a special attention on the arteriovenous fistula. This is the selective arteriography. An endovascular treatment was discussed and performed. The patient underwent an endovascular treatment, distal embolization of the gonadal vein with particle coiling in the communicating artery due to closure of the AV fistula. You can see the vein embolization. On the second postoperative day, patient showed significant clinical improvement. In 30 days, she was asymptomatic, without complaints, and there was no sign of recurrence. The follow-up of the 6 and 12 months were the same. The endovascular intervention, embolization combined with coiling of the artery is the best minimally invasive treatment option with 100% success rate and very low risk of relapse. Thank you for the attention.
Thank you so much to you, Elena. Any further comment from your side?
So I think this is a very good method to resolve this problem, but you have to attack in the same time the venous part of this formation, also the arterial one.
And any comment from the OBGYN or vascular board on this?
Actually, this is a very rare case, I think, of arteriovenous, let's say, malformation. So, of course, I mean, the treatment is effective, but this does not actually represent the cases of, the pelvic congestion syndrome. So in that case, the treatment is obvious, I think, and it's successful. But how often you face, I mean, such condition, this is.
And I asked the technical team, I see David Beckett, who is a dear friend and a great expert, is in the audience. So if like a technical team can bring David Beckett as panelist, because he's asking if you consider Onyx as an alternative. So while we are waiting for having David with us, Zaza, were you raising at the end? Were you making any comment on this?
Yes, Sergio, it's a very interesting case and a very rare case, and excellent result. And technical methods is maybe different, and Onyx is I think a good choice for this case, because it's possible to use for arterial and also for venous part of the malformation, but also why not different embolic materials in for the treatment of the malformation is also possible. It's some what choose the doctor, yeah, because
yeah,
it's with which embolic materials is more familiar. It's I think.
And I see David is with us, so welcome, David. If you want to unmute yourself, we cannot see you, but I see you are there with an open mic.
Hi there, David Beckett, interventional radiologist at the Whiteley Clinic. The reason I asked about Onyx was because obviously, if you're saying this is a true arteriovenous malformation, then if this was, say, a peripheral malformation in the thigh, for example, an arteriovenous malformation, you wouldn't use coils. You would want to get into the nidus of the malformation. So I was just thinking that Onyx, therefore, would be the better choice if it was a true arteriovenous malformation, as in a congenital malformation. I might have missed that there was this post-cesarean section. Did this come about? Do you know?
Elena, was this post-cesarean? Was post-C-section?
Sorry, I was undistracted.
Was this after post-cesarean section?
After a cesarean section.
Because they're the times when I've seen this twice, and I've seen it once post-cesarean section where you've got a simple arteriovenous malformation whereby I think you can coil that simple connection where you've got single artery, single vein almost. And then I've just recently had one, probably last year, that Angie is one of the sonographers at the clinic, sent across, which was a true arteriovenous malformation, and that one will need onyx because there are multiple nidi and multiple communications.
That's very interesting contribution, David. Thank you. Since you're here and you're a great expert, one of my comments would have been on the 12-month follow-up. We know that it can take some months before single results, and we should have like maybe longer follow-up potentially. So what would you consider a reliable follow-up in pelvic venous disorders? We know that in varicose veins we talk a lot about not less than 5 years.
So
follow-up in an arteriovenous malformation or follow-up in general?
Pelvic venous disorders. If we have to go on looking for objective data in pelvic venous disorders.
I guess I always think the clinical follow-up is the best follow-up. I mean, we're not going to do anything, are we, unless the patient's clinical symptoms deteriorate. So sure. I think that clinical follow-up. But I mean, if you want an objective measurement of reflux, I would always say it's going to be transvaginal and transabdominal scanning.
No, but the question is like rather than 12 months follow-up, to really be solid in the results, should we go like 3 years in re-evaluating the patients or what?
I mean, I guess I think I would probably be happy at 1 year, providing that the patient then doesn't undergo any significant sort of lifestyle changes, as in, you know, she doesn't get pregnant again, for example.
And are you scheduling a control a long time, or just in case of symptoms reappearance, usually for these pelvic venous disorder patients?
Sorry, Sergio, what was that?
Are you going to schedule a follow-up after 1 or 2 years, or they come back just if there is some symptomatic recurrence?
Yeah, so our standard follow-up is just if there is symptomatic recurrence.
That's it. Elena?
I would like to comment the operation is the operation in the presence of arteriovenous fistula. I think it is more risky for a hemorrhage. I think that we have to, first of all, to do sclerotherapy or to coiling and minimize this arteriovenous fistula. And if we cannot have sufficient improvement, we can do operation, but no to performing first operation because we have a high risk of hemorrhage.
David, any comment on this?
I absolutely agree. I would never operate on any arteriovenous malformation if I could help it.
Perfect. So thank you so much for your contribution, David, and also Elena. Now we finally go back to Mamuka Bokuchava. It's my pleasure to introduce him, like another giant in the field from Georgia. So we are basically in their place today, virtually it's Vein Week Georgia, this event. So Mamuka, your case.
Thank you.
Okay, Mamuka, I try to share your presentation.
Yes, first of all, we have my recorded speech, and I will comment several words after my recorded speech, okay?
Thank you.
Okay, it's...
we can see it, but we cannot hear. So play it.
Okay.
Dear Zaza, dear Sergio, dear colleagues, first of all, thank you very much to give me the opportunity to take part in this very important online webinar. Pelvic venous disorder, as you know, is a complex, underdiagnosed cause of chronic pelvic pain in female patients. However, pelvic pain may be caused by many other pathologies, including gynecological, urological, gastrointestinal, and musculoskeletal system. Therefore, imaging is critical in the evaluation of pelvic venous disorders to differentiate it from other conditions and to detect its cause. Multiple etiologies may be responsible for pelvic venous disorders. This condition caused by incompetent gonadal vein valves. Secondary causes include retroaortic left renal vein, mesoaortic compression of the left renal vein, nutcracker syndrome, May-Turner syndrome, inferior vena cava obstruction, vascular malformation, and chronic hypertension. Hormonal factors, reproductive age, and multiple pregnancies are also widely acknowledged risk factors. Most women present with non-cycle, intermittent, constant pelvic pain for more than 6 months. Other symptoms include dyspareunia, dysmenorrhea, and urinary disorders. The clinical examination is very important and may reveal varicose vein of the vulva, peroneum, buttocks, and lower extremities. However, pelvic venous engagement and gonadal vein reflux can be seen in patients without pelvic pain. Thus, the diagnosis of the pelvic venous disorder is made based on patient symptoms, clinical examinations, and imaging studies. Embolization of the ovarian veins and pelvic varices is the treatment of choice of pelvic venous disorder. Treatment failure is explained by the complex anatomy of the pelvic veins, which show a wide variation in terms of trunks, venous valves, duplications, or crossover connections. Furthermore, reflux often affect more than one pelvic vein, which makes it difficult to identify and treat all patterns of reflux, leading to the development of alternative reflux pathways and recurrence after treatment. The diagnosis of pelvic venous disorders is made through a combination of the patient symptoms, clinical and radiological examination. The gold standard test for diagnosis is venography. However, due to the invasive nature of venography and exposure to ionizing radiation, it's reasonable to limit this use of these patients with a high suspicion of pelvic venous disorders with the intent to treat it. This makes it necessary to have a reliable, non-invasive imaging modify that is suitable for screening and can yield consistent results in the patient's clinical presentation. Ultrasonography is core duplex alone of dynamic examination of flow in the pelvic vein. The later periuterine and periovarian vein can be identified in pelvic venous disorders. It has the advantage of using the Valsalva maneuver for examination of patients in an upright position to detect reflux. However, sonography does not readily show the ovarian veins. It has limited sensitivity for obstructive causes of pelvic venous disorders and other conditions that cause pelvic pain, for example, endometriosis. Therefore, valuable diagnostic guideline to identify a patient with pelvic venous disorders is very important. This guideline must be easy and clear not only for the vascular specialist, but also to the gynecologists, urologists, internal medicine specialists, especially for radiologists who makes invasive and non-invasive procedures to patients with pelvic pain. Thank you so much.
Thank you so much to Mamuka. Mamuka, any other comment?
Yeah, several words. It was very interesting for me to take part of so many very interesting discussion between vascular specialists and gynecologists together. Usually we receive the same patients with pelvic pain from gynecologists when they excluded some gynecological reasons for pelvic pain. That's why in our future work will be very interesting one direction to improve the knowledge about the pelvic pain, not only specialists, vascular specialists and gynecologists, and to the patients too, because patients with a pelvic pain the first time go to the gynecologist, and it's very important to us to make guidelines for the diagnosis guidelines. It would be very clear and very easy for the gynecologist, for the urologist, for the vascular specialist, and especially for the radiologist to make non-invasive procedures for the patients in their clinics to differentiate patients with pelvic pains. Thank you so much. Thank you so much for a very interesting discussion.
Thank you so much, Mamuka. I would go back to the OBGYN colleagues, asking if they have any comments on this presentation, and if not, what is their approach in terms of finding incidental venous dilation? So what is usually your protocol if you say like venous dilation or potential venous
involvement? May I ask a question? I mean, what is the place of embolization? I mean, now, and what are the indications according, to the vascular, let's say, experts?
Mamuka, would you like to take it from there?
Yes, I think embolization is the treatment choice for the patients with the pelvic venous disorders, and I think this method it's a choice of the treatment for the vascular specialist the first time. Yeah.
And then what is the risk, I'm sorry, what is the risk in this case to have afterwards ovarian dysfunction? Because for us, in women of reproductive age, it's really very important, the ovarian function. And, sometimes after embolization, we have some problems, and this is really very important. If you don't have clear indications for treatment, if you don't have clear indications, that the symptoms are related to the pelvic vein syndromes, and if you go for embolization and afterwards, you will have ovarian insufficiency. This is really very important for a woman.
This is indeed
yes.
the key of...
Please.
No, I was just saying, this is exactly the key vision of this gathering, because in our experience, of course, once there has been an appropriate symptomatic evaluation and exclusion of gynecological concerns, but that's when we should learn more from you. I think we see good results. The problem I see is when there is an over-treatment or a treatment that has no proper diagnosis behind. And indeed, I was expecting David Beckett raising already the hand. So Mamuka and David, if you want to jump in again.
Hi, yeah, I mean, I think that's a valid point. What I would say about ovarian dysfunction is I've never ever seen ovarian dysfunction occur ever after ovarian vein embolization. So in over 1,000 cases, I've seen nobody with ovarian dysfunction. Now, the thing to bear in mind here as well, and I would say it's analogous to testicular vein embolization. So when we embolize a male testicular vein, which is just the same as an ovarian vein, we do not see male testicular dysfunction. If anything, we embolize a male testicular vein sometimes to improve fertility. So, gonadal vein embolization has been shown to increase sperm motility. Some people have postulated, obviously, that will therefore increase fertility, and others haven't said that jump. But I think we don't see ovarian vein embolization cause ovarian dysfunction.
Honestly, I'm not aware of papers on this. Is there any publication, David, or the other experts about embolization and the issue that was brought by Professor Grimbitz?
So there isn't, and of course, what we're basing all of this on is the male version, and the fact that we're not seeing infertility in females. However, that would be an excellent topic of research if we wanted to research that, and that should be a really easy topic to research.
But we are also with the top experts of the OBGYN over here, so I'm really curious.
My question was exactly that: how the 1,000 cases, the ovarian function was evaluated, the measurement of anti-Mullerian hormone, or because to be objective, it's important to measure those outcomes.
Yeah, that's such an important topic. So do you have on the other side a publication that is correlating embolization with anti-Mullerian?
Yes.
So there is some publication on this.
No, I'm asking about those 1,000 cases.
No, I understand.
Yeah, no, and you're right. Those 1,000 cases are purely on a clinical basis only. So those patients have had no change or abnormality in their menstruation. They've not been pushed into premature menopause. But this is fantastic, because this level of research is what we should be having, and we should see that, because that's a huge number of patients. And if I could turn around to you and say what their actual ovarian function was, I mean,
yeah, but the problem is that there is a difference between the menstrual. Let's say
I know that, but what I'm trying to draw parallels to, though, is what we do know in the male version of it.
But it could be also a big jump.
It's really very important. So in females, this is really very important. And also there is a very big discussion. I mean, for example, for endometriosis, if you are doing surgery for endometriosis, what is the impact on ovarian function and, you know, or no site quality or maybe on site number. So I think that, you know, Helder previously talked about AMH. So, you know, if you stay only to if there are differences in the menstrual pattern, this is insufficient, you know, to study, you know, the ovarian status before and after embolization. So we have to be very careful because, you know, we are dealing with probably young women with pelvic pain, that they are really interesting for, you know, to become pregnant. So
it's a great contribution.
There are no clear indications. We have, you know, and if there are no studies, we have, you know, to be very careful how we indicate, I mean, you know, those kind of treatments. And there are, you know, probably some data, you know, from embolization of uterine arteries. Of course, it's different than the veins. And there we have some problems, I mean, you know, with ovarian function and also, you know, uterine function afterwards.
Grigoris, it's my understanding, it's so good that you're telling us this, but it's my understanding it's not that difficult to throw a study of this type. You're basically needing a blood testing, right?
I don't think that it's quite easy, but you know, it's something that we have to study from different, you know, let's say perspectives, because you know, you can study the AMH levels before and after. You can see the antral follicular count before and after, and also you can see what are the pregnancy rates, I mean, you know, after, I mean, embolizations. So you can see also, you know, but this is probably, you know, to study the age of menopause after those kinds of interventions, because usually you don't have changes, I mean, in menstrual pattern afterwards, I mean, in 1 or 2 years. But maybe because of the impact on the ovarian, you know, status, then you will have the menopause, you know, some years, you know, let's say earlier. So this is also important. So there are still open issues, and also, you know, we have to be very careful, you know, about, you know, the treatment options. If we are not sure that they are effective, we don't have, you know, real, you know, published data on that. We don't have evidence-based data, and we have really to be very careful. This is why, and this is the importance of this group, we have to start from the beginning, as also, you know, Erdan and also, you know, Helder told before, I mean, in the beginning. And we have to start from the beginning, because otherwise, I don't think we will repeat the same, let's say, story than in the past.
Sure.
You know, we will discuss a little bit now, and then afterwards, if we don't put, you know, something very clear in terms of definitions of, you know, diagnosis, of the use of non-invasive techniques in diagnosis, what are the treatment options, what are open in the treatment options, what are the advantages or probably the disadvantages, so what has to be studied. So this is, you know, something that we have, you know, to put on the table now.
Great contribution. Thank you so much. Zaza, you have a raised hand there?
Yes, Sergio. It's a topic which need to systemize our knowledge, because there is no some evidence that after the embolization, ovarian function is depressed, yeah, but there is a lot of cases that after the treatment of pelvic congestion syndrome with embolization, there is a increase the ovarian function, and we have many patients from the reproductive clinics. After this, they began the normal life and normal functioning, and also there is this is opening because there is a lot of materials, but not some synchronization of this and harmonization of this data. And this is a reason because we cannot talk about the strong information, strong data that embolization don't influence on the fertility, fertile function. And I think it's a great topic for future cooperation. It's very interesting. Another question is how to treat this patient with primary pelvic congestion syndrome. No embolization, no surgery. What to do? Because the surgery on the organs like an ovary, this is like a shot on the squirrel from the tongue. Like it's my opinion. And another term is also the conservative treatment with this hormonal treatment. It's also very have the very difficult results sometimes.
Okay. Thank you so much, Zaza. For the sake of time, we have to move faster now. We have other two comments, one from me and one from Pierluigi. We start with Pierluigi so that if there is time, I will go also with mine. Pierluigi Antignani, already introduced him, is the president of the International Union of Angiology, dear friend and a great professional for our field.
But from the discussion, I think the best point is to define correctly what is this disease, because we have the need to have a simple questionnaire, a very simple questionnaire, use us as a phlebologist, but also gynecologist, to identify what is the phlebological problem and what is the gynecological problem. This is the first step. After this, we can start with isolate the patient with the venous problem and treat. Together we publish the guidelines in the International Union of Phlebology about this, and we define that the best method is the sclerotherapy, foam sclerotherapy, for the pelvic congestion syndrome and for this condition. Of course, the iliac stenosis we have to treat by other method, but the majority of patients have the pelvic congestion syndrome. So we have to use a specific method, poor invasive method for this congestion syndrome. But we have to, it is very important to create a link between phlebologists, angiologists, and gynecologists to speak the common language and to define correctly these patients. Because my experience with our colleague in Italy, a majority of gynecologists see the varicose vein, but don't consider this as a very important problem. It's the only definition of a morphological condition, but stop here. So it's very important to share the information and increase the acknowledgement in this topic.
Thank you so much, Pierluigi. I will just go with the final last comment on my side, because I was pretty impressed by a publication that was done on the topic of the incidental periuterine venous thrombosis. So I was wondering how much we are aware about this issue, meaning that in our field, whenever there is a venous reflux, there is inflammation, and indeed it has been demonstrated that we have an increased risk of thrombosis in the lower limbs. This is the paper by Amin that came out in 2020. That was showing something that for me was pretty impressive. They look at 1,383 women going to the gynecologist for whatever reason, not for any particular symptoms, 3% of them had an incidental uterine venous plexus thrombosis. Now, this was also associated with an odds ratio of 3.15 with the leg varicose veins, and I don't want to take time now, we don't have time. But as I was saying, we have demonstrations in the literature that whenever there is a venous reflux in the lower limb, you have an increased risk of, for example, DVT up to 5 times. So we have publications like this one talking about the unmet needs in pelvic venous disorders, and we never talk about this, and we are talking a lot in our field now about also the issue of COVID, so then the endotheliopathy that there is behind that, and the potential presence of a positive asymptomatic patient that is more prone to thrombosis. So with this, I conclude my unmet needs. The time is really short. I don't know if somebody wants to comment on the last 2 things Pierluigi and I said. If not, I ask Zaza and Grigoris to give the next actions we should take, and then a final remark from Basil. See Sarit again?
Yes.
Yeah.
So on the presentation about, gynecologists not taking action when we see pelvic varicosities, is that the issue is that, we see them all the time. We see them in women who have unrelated surgery, not necessarily because of pain. So it's difficult to know the significance of pelvic varicosities that we see. So they don't, not all women with pelvic varicosities will have pelvic pain. So this is again another problem. That we are not actually 100% convinced that there is a significant association between pelvic pain and pelvic varicosities. And again, going back to what I said earlier and what Grigoris reiterated is we need to define the condition and its symptoms better before we can move forward. That is probably a good way to start.
Thank you so much. It was a great debate, of course, and we now give the words to the representatives of the vascular and of the OBGYN ward for final remarks on next actions. So, Zaza, would you like to say a word on this?
Yes, and thank you, Sergio. It's, in my understanding, it's a real discussion. It's great discussion, which we saw during this 1.5 hour. And it's really, we have some topics according which it's a hot topics, and we start to work together very, very actively. And the main question was the diagnosis of the pelvic venous disorders, correct indications for treatment, and also the follow-up, not only from the vascular view, but also from the gynecologist view. And I think that this last topic about the influence of the embolization on the ovarian function, it's very, very interesting, and I think we can start work on this, because it have not only the medical value, but also the social value, and so it's a social problem. And I think next one of the next action what we must to do is to share our knowledge, what we have the main documents from one side, the vascular professionals, what we have, and another one, gynecologist, and look in which topics is the differences and go working to make the decisions and make the consensus on this area. I think it's a main, and first of all, I think together with you and all EPVA vascular part will preparing the some main documents on this area and send to our colleagues future. And also we must to working on the real epidemiology of the pelvic venous disorders. How many how is the percentage of the pelvic venous disorders in the patient with the pelvic pain, and another one, how is the percentage of the pelvic venous disorders in patients with chronic venous disease of lower extremities. It's very, very interesting topics, and epidemiological study will be done on this area. I think with on the basis of our last webinar and today's discussion, we can preparing the minutes of these two meetings and present to our colleagues, not to only to gynecologists, but all participants of the European Pelvic Vein Alliance.
Thank you, Zaza. I have already took note of 10 topics that we will share for sure and more. And now it's our pleasure to have Professor Grimbitz giving some final notes together also with Professor Basil Tarlatis.
I think it was really a very nice and very useful meeting. And for me, we have, to start very systematically to think about this topic. And if you would like to start systematically, for me, the next probably action should be, to form a working group, on that issue. And the first, let's say, aim of this working group will be, to give a clear definition of what we are thinking that it's pelvic congestion syndrome, or, vulvar varicosities, in general pelvic vein syndrome. And then we have, to clarify what will be the potential impact of this to women in terms of pelvic pain or other kinds of pain, dyspareunia or something like that, maybe the impact on infertility. So to mention the potential symptoms that could be related to that, just to be open for studies, to stay away at this, from treatment proposals, but having this as a starting point, we can mention some open, let's say, topics for research, other epidemiological research, or maybe clinical research. So this will be a real scientific contribution. And as far as I can understand, the pelvic, your group is really an alliance, not, let's say a society, a scientific society, which is really very good because you activate a lot of people, from, your field, in different topics. So but for the females, we can use the umbrella of EBCOG together with SG. Actually, we have between us the SG editor-in-chief of Fact User Vision, which is our official journal, and probably Basil will comment a little bit later. As EBCOG, they have their official journal. We can prepare, some, let's say, manuscript, just giving this and to be published in the official journals as a starting point, to start again discussing in a very objective way about pelvic vein syndrome. So this is probably my proposal. And, another question, if we decide to go on that way, the next question is who will participate? And it is for me obvious from this discussion that we have today that we need the vascular experts, we need the gynecologists, we need the imaging experts, probably radiologists, and from our field, we need probably ultrasound experts, and we have a lot. So if we decide to go that way, and this is from Basil to be comment, I mean, and who will take the initiative, my view is that we can go in this direction, and SG is really willing to participate, and I hope that the EBCOG is really willing to participate also. Thank you very much. Congratulations. Thanks for the invitation.
Thank you so much, because indeed this is the vision of moving from a discussion toward evidence-based data. The reason of this group is indeed bringing science and not just discussion. So I totally second your vision, and the vision started thanks to Basil, so it really makes sense that he closes what he started together with us. So Basil, the mic goes to you. If you're there, I know he's busy though, because he has you're there. Fantastic. I thought you were like in an overlapping.
I'm still there. Yes. Because
thank you so much.
In the meantime, we have some meetings for.
Yeah, I know you're like multitasking. Thank you.
But I try to follow the discussion as well. So number one, I need to say that I'm very happy that we had the opportunity, thanks to your invitation, to join this effort. Number two, I would like to ask my colleagues from ESGE, the Grigoris, Helde, and Professor Saridogan for accepting this invitation to join forces and try to work together in this initiative. And I have discussed it in the EPCOG executive, and they were supportive in moving forward. So I'm happy to say that we are fully supporting that, and we can try to assist in areas where we can in order to promote this initiative that we discussed. And I think, as you said, it is important, and I think many of you have discussed that, it's important to focus on areas like diagnostic criteria, classification, all these things that are important, and you are the experts to do so. And I also agree with what Grigori said before, that most likely you may need some other expertise, like ultrasound experts and so on, in order to be able to improve the diagnostic capabilities and so on. So anyway, I think there's a lot of things that can be done, and from our side, we would be happy to work together with ESGE and you in order to move forward this important initiative. And you can count on my support, and I will try to attend whenever possible your initiatives and discuss, but also we will discuss internally, because as Grigori said, ESGE is part of EPCOG, is a partner in EPCOG, covering the area of gynecological endoscopy. And so it will be important that we have this bridge between some of us in EPCOG are fetal maternal specialists, others are urogynecologists, oncologists, I'm a reproductive specialist. So there are all kinds, but it's important that we can have a bridge so that we can work together and move this initiative further down. So thank you very much.
Thank you so much to you, Basil. Thank you for being a wonderful example, as I said at the beginning, of professionalism and also of humane quality. On my side, I will close with one of the founding members of the VWIN Foundation, because also in this case, nothing would have been possible without the team, and that's Professor Ci, in the representation also of Professor Bottini.
So Sergio, from my side, molto grazie. Molto grazie.
Grazie mille a te.
Okay.
Here is Professor Ci from University of California.
Thank you very much.
Thank
Thank
you.
you.
Good afternoon,
Thank you.
good evening. I hope you all have enjoyed this excellent program by the European Board and College of OBGYN and the European Pelvic Venous Alliance on this particular topic of multidisciplinary unmet needs in pelvic venous disorders. I will see you soon. Thank you.
And with this, we conclude this first day of the Vein Week. As you know, we are in the week dedicated to vein awareness around April 7th, that is the World Health Day. So I deeply thank literally all the world that is now developing activities. And Professor Bottini was not with us because he's now in Latin America at the simultaneous time doing other activities. So I wish you all a nice week and also a nice Vein Week. And thanks so much to the OBGYN colleagues for this historical moment, and looking forward for the next one. I ask the technical team to play the video, and I wish you all a nice evening, afternoon, or morning. Bye.
Good night to everybody.
Bye-bye.
Bye-bye.
Bye.
Thank you. Bye-bye.
Bye.
Bonjour à toutes et à tous, c'est bientôt la Vein Week, la semaine de la veine.
It's very important. Both public and health professionals are aware of appropriate venous lymphatic management.
Incluso, más del 50% de la población podría estar sufriendo enfermedades venosas y linfáticas.
Não se esqueça, tromboembolismo venoso é uma das principais causas de morte e que pode ser prevenida.
I që po nastojaštem limfedema su opredele preduskrite epidemija.
السلام عليكم جميعا. هل تعلمون أن الدوالي ليست فقط بالساقين، وإنما أحيانا توجد في أوردة الحوض، وقد تصيب النساء في منتصف العمر. وأهم شكوى في هذه الظروف هي وجود آلام مبرحة في منطقة الحوض قد تتعدى 6 أشهر. فحين ذاك لابد أن نفكر في أوردة الحوض قد توجد بها دوالي. وشكرا.
იწვევს ეგრეთ წოდებულ მენჯის ვენურ დარღვევებს, რომელიც წარმოადგენს გენდერული თანასწორობის საკითხს, განსაზღვრავს როგორც დავიწყებული დაავადება.
Ανυπομονούμε για μια εξαιρετική εβδομάδα φλεβών που προάγει μια υπέροχη υγεία των φλεβών και των λεμφικών αγγείων.
أنتم مدعوون في الفترة من 4 إلى 10 إبريل لإنشاء مبادرات أسبوع الوريد في بلدكم.
Promuovendo educazione basata sull'evidenza.
社会の方々や施設の方々にお知らせしましょう。
नमस्ते। हमें अपने एरिया में वेन्स और लिम्फेटिक्स की हेल्थ को इम्प्रूव करने के लिए एजुकेशन एंड कोशिश करते रहनी चाहिए। Thank you.
Interactuando con todos nuestros colegas alrededor del mundo.
各位同道们，早安、午安、晚安。
And good vein lymphatic health. See you at
Vein Week.